as I say to patients, especially with early diagnosis, they're going to be here for a long time. I hope you're saving for retirement because you're going to be here for a long time. It's not breast cancer that you're going to statistically die from. We will all die. But women with breast cancer have nothing but hope out there. But early diagnosis is key.
Hello, and welcome back to 20-Minute Health Talk. I am your host, Sandra Lindsay. Breast cancer continues to affect millions of women and families around the world. For many, hearing the words, "you have breast cancer," can be overwhelming, filled with fear and uncertainty, and many questions about what comes next. Whether you're navigating a new diagnosis, supporting a loved one, or simply wanting to learn more, understanding the treatment journey can make all the difference. Today, we're breaking it all down, from the importance of early detection to the latest advances in surgical care and recovery. Our goal is to demystify breast cancer, educate our listeners, and remind everyone that hope and healing often begin with awareness and understanding. Joining me today is Dr. Susan K. Boble, System Chief, Breast Surgical Oncology and Breast Program, and Vice Chair of the Cancer Institute at Northwell Newlands Health System. She also serves as Chief of Breast Surgical Oncology and Breast Program at the Dyson Breast Center. Dr. Boble performs a wide variety of breast cancer surgeries, from lumpectomies to mastectomies, and has dedicated her career to helping patients navigate their treatment journeys with expertise and compassion. Thank you so much, Dr. Boble, for being here today.
Well, thank you for having me, and thank you for doing this. It just gets the word out on so many levels, so thank you.
My pleasure. Before we even get into treatment, I'd like to start at the beginning, the most powerful line of defense, which is early detection. So, what are the current recommendations for breast cancer screening, and why is knowing your body and getting screened so incredibly important?
Oh my, how much time do we have? It is so complicated. So the straightforward answer is that women of average risk for developing breast cancer should really start getting mammograms at 40 years old and every year after that. Now, there's been a lot of debate back and forth about that, and that really is where the recommendations are today. So to know if you're at average risk, you do need some risk assessment. And surprisingly, and I say surprisingly because I don't think it's done often, is that risk assessment is supposed to be done at about 25 years old and then almost yearly after that. Now the question is, what goes into risk assessment? And
Correct.
There's so much. Your family history goes into risk assessment. Your BMI, or body mass index, which is your height and your weight, goes into risk assessment. And the reason is because being overweight is a risk factor for breast cancer and multiple other cancers. So these are all really important things. Lifestyle goes in. Your family history is very important. But, and we get hung up on this because we think, oh, I don't have any family history of breast cancer, so I'm okay, I'm not at risk. The truth is, about 80% of women who develop breast cancer have no family history. So,
about 80%?
Yes. See, isn't that shocking?
That's very shocking.
I know. Everyone is always shocked at that because all we do is hear about family history, family history, family history. It's only significant if you have a family history of breast cancer. Otherwise, it really puts you at average risk.
Wow. So that's shocking to hear. So let's talk about, you mentioned mammogram, but what about, clinical breast exams at home, breast self-awareness, checking your breasts in the mirror, checking for lumps or, disfiguration of the breast?
I think every single thing you mentioned is very important. I mean, you're spot on with all of those things. And the key is know your body, not just with breast cancer, but skin cancer and all these different things. You see a new mark, you see a new, what you think may be a freckle or a mole that hasn't been there. Well, why did it show up all of a sudden? Then you go to your dermatologist. So in order to know something that's abnormal, you need to know what your normal is. And everyone's normal is different. So that's why it's important to know, are your nipples inverted? Have they been inverted since you were born? Well, then we're not concerned about it. But if you're 65 years old and all of a sudden one of your nipples is inverted, that's a significant finding, and we need to investigate the cause of that. So it's that and many other reasons why it's so important to know your own body.
That's true. And in addition to mammograms, now we have ultrasound and MRI based on the density of your breast. And I know for Black women, we have denser breasts. So in addition to my mammogram, my physician will say, I need a mammogram with ultrasound.
Correct. So we throw around this term density or dense breast, and I in my office use it almost every day. And the question is, what is it really? And how do women know if they have dense breast? So underneath the skin of the breast, there's two types of tissue. There's breast tissue, which is firm and nodular, and there's fatty tissue, which is sort of like jello. We all have both. It just depends on the ratio. If you have more breast tissue than fatty tissue, you have dense breasts. If we do a mammogram, we can tell that difference. So the problem with dense breasts is on a mammogram, breast tissue shows up as white. Fatty tissue shows up as gray or black. Masses show up as white. So when we're looking for a white mass on a white background of breast tissue, very difficult to see, as compared to looking for a white mass on a background of fatty tissue, which is gray or black, much easier to see. So dense breast tissue in and of itself is just how we're made. We cannot control for that. But it's a minor risk factor for developing breast cancer over your lifetime, and it makes mammograms more difficult to interpret. So that's where the ultrasound that you were just referring to comes into play. Because if you have dense breasts, getting a mammogram is still critically important, but it's not enough. So that's where an ultrasound or an MRI comes into play for screening.
Great. So thanks for clarifying that. So essentially, just staying informed and being proactive is key.
So important. Another thing about breast density is if we do a mammogram, say on 100 women in their 40s, meaning still getting their period, about 70 to 75 will have dense breast tissue because our ovaries are producing hormones. The hormones stimulate the breast tissue. After menopause, that ratio changes because our ovaries are no longer producing hormones, no longer stimulating the breast tissue, so it frequently goes away and is replaced by fatty tissue.
Got it. So once an anomaly is detected and a diagnosis is made, that's often when a patient meets someone like you. What exactly is your role at that point, Dr. Bobo?
So patients come in at all different times. Some women will come in because they noticed a breast mass, and they'll see their gynecologist, and their gynecologist will send them to us. So we see patients both with benign findings, meaning not cancer, and with cancer, or just abnormal findings on a mammogram or an ultrasound. So frequently, if they come in with an abnormal mammogram or ultrasound, we'll arrange for what we call an image-guided biopsy, a biopsy with the mammogram machine or an ultrasound machine or the MRI. But if they have an abnormality that needs to be biopsied, we'll arrange for that. Then the key is, what's the pathology show?
So before we get into what the pathology shows, I'd like to just get some clarification on biopsy, because there are a lot of misconceptions and just differences in perceptions about biopsies.
And myths.
So you sound like you know where I'm going exactly. So why don't you take it away and explain for our listeners the controversies with biopsies and what's accurate and what's inaccurate?
So I would say one of the biggest misconceptions is, well, if you put a needle in my breast and there's cancer there, it will spread it all over. And I do understand why people think that, but for breast cancer, it is not true. It is not the case, and we know that from decades of studying it. Now, years ago, say in the 1990s, when a woman had an abnormality on her mammogram, they would go right to the operating room and remove it. And over the years, we realized, thankfully, we don't need to do that. And there's other ways that are perfectly safe and recommended to do that biopsy. If we see an abnormality only on a mammogram, then we do a biopsy with the mammogram machine, and that's called a stereotactic biopsy. If we see an abnormality on the ultrasound, then we do the biopsy with the ultrasound, and that's called an ultrasound-guided biopsy. If we only see it on an MRI, then we do an MRI-guided biopsy. But the key is, if there's an abnormality on any of those imaging tests and we need to do a biopsy, doing what we call an image-guided biopsy is safe and the recommended way to do that biopsy.
Well, thanks for that clarification. But before I stopped you at biopsy because I know that's such a, controversial issue. You were going on to say something else about when the patient comes to see you, they see you whether, just for a benign mass, or they may have already been diagnosed with breast cancer.
Right. In any given day, any breast surgical oncologist will see women sometimes with breast pain, and they're worried about it. If I can make someone feel better, just putting them at ease that their breast pain is just along with their menstrual cycles and it's totally normal, that's great. I've put them at ease because every woman, when she feels something in her breast, they go to cancer. Let's face it, we all do. That's human nature. And we're surrounded by breast cancer, especially in October. It's everywhere. So if we can put their mind at ease and let them get back to their normal life, that's winning every day for everyone.
It's so anxiety provoking, just, going in to get your mammogram and or ultrasound done.
Even when you don't have any symptoms, it's anxiety provoking.
Exactly.
But necessary.
Necessary. So we can't stress enough how important that early detection and getting screened is.
It is the answer to everything. So since about 1990, every year, 2% fewer women die from breast cancer because of early detection and better treatments. But without early detection, it's very difficult to control.
That's amazing. We've come a long way.
Oh, so far. We have so far to go, but we've come so far.
We've come a long way. So I understand you deliver good news and not so good news. So when you have to deliver news that the patient has breast cancer, then what's next? How do you navigate that?
So there are many different avenues of treatment, but it is key to remember that just in the United States alone, over 300,000 women are diagnosed with breast cancer every year. Those numbers are mind-boggling. Another shocking statistic here.
How does that compare to other countries, other, developed and developing countries?
So we have, and it varies. So the overwhelming majority of our breast cancer diagnoses are early diagnosis. Stage 0, stage 1, stage 2. But that's because of our screening program. If you go to other countries that do not have screening programs, the majority of their diagnoses are late diagnoses. So screening saves lives.
You can't say that enough.
I know.
So before we go into the surgical options, though, let's talk about the staging, because there are a lot of confusion as well around staging. Stage 0, what should we do? Just remove the lump and go on with our lives? Or, what are the different stages?
So there's two main types of breast cancer. Mm-hmm. There's ductal carcinoma in situ, which is a pre-invasive breast cancer, and there's invasive breast cancer. The difference between them is that ductal carcinoma in situ, or pre-invasive breast cancer, does not have the potential to leave the breast. So it stays in the breast. Invasive breast cancer, thankfully, it typically does not travel outside the breast, but it does have the potential to leave the breast and go to other areas of the body. So ductal carcinoma in situ, which is stage 0, is the earliest possible form of breast cancer because it does not leave the breast. But there's some controversy with treating ductal carcinoma in situ because it does not leave the breast. So if we do nothing about it, will it change? And if we do nothing about DCIS, or ductal carcinoma in situ, some women will die with it, not of it. And it will just stay there and do nothing. Other women, if we do nothing about it, their DCIS will progress and become invasive cancer, which is why we treat all of it right now, because we cannot tell the difference. So you may have heard of over-treatment of breast cancer. And that's what this is talking about, is DCIS, because some women, it would do nothing but just stay in the breast. That is true. We just cannot differentiate which women it will stay there and do nothing, and which women it will progress and become invasive cancer. So presently, right now, we treat all DCIS. Hopefully in the future, we will have a better way of telling the difference, and then we will only treat the ones that would progress and become invasive cancer.
And that brings us to the end of another episode of 20-Minute Health Talk. A huge thank you to Dr. Susan Boble for this incredibly important discussion. Remember, taking charge of your breast health is a year-round commitment. Please talk to your doctor if you have any concerns. We'll be back next week with part 2 of our breast cancer series with Dr. Susan Boble. Until then, stay healthy.